is growing, so that's good. So we'll start. So good morning and good afternoon, everyone. Thank you again for joining and for taking the time to participate in this webinar and on intersections on human trafficking and substance use, trauma-informed care and collaboration strategies to support survivors. My name is Monica Arenas from Futures Without Violence, and this webinar is part of a project called Building Collaborative Responses to Traffic Victims of Domestic Violence and Sexual Assault. And we thank the Department of Justice and Office on Violence Against Women for their support. As part of this project, we offer different webinars, trainings, and we also have put together several resources on collaborations to support survivors of human trafficking. So feel free to introduce yourselves in the chat, and please keep in mind that the public chat is open and visible to everyone participating in this webinar session. So be careful, please, not to share private or confidential information. For accessibility, closed captioning is available, and it can be accessed through the bottom toolbar on your screen, and you'll see a CC closed captioning icon. Sign language is also available, and thank you for the captioners and the interpreters for your support with this. The recording, slides, and handouts will be sent to you next week and will also be posted on the website for you. And also we will share the PowerPoint, the handouts, the bios for participants in a second through the chat. And next slide, please. So we're grateful for the participation of our co-presenters, Katie Spriggs and Dr. Erin Stewart. Dr. Erin Stewart is the Chief of Psychology and Interim Assistant Medical Director for the University of Vermont Health Network, Chaplain Valley Physicians Hospital. She's the co-chair of the State of Vermont Human Trafficking Task Force and also co-chair of the Human Trafficking Task Force Housing Work Group. And among her many recognitions, Dr. Stewart received the State of Vermont Crime Victim Services Career Achievement Award for exemplary services to victims and initiatives that support survivors. And also, we are grateful for Katie Sprague's participation. She has worked in victim services for over 8 years, with a focus on victims of domestic violence, sexual assault, and human trafficking and stalking. And she's also a member of the West Virginia Human Trafficking Task Force and co-chair of the training committee and a steering committee member. And Katie is the executive director of the Eastern Panhandle Empowerment Center. And we'll share a handout with their bios in a second. And so we'll go to the next slide. So now we'll review briefly the learning objectives for this webinar. As shared in the outreach flyer, as a result of this webinar, we hope that you will be better able to apply a trauma-informed approach to support survivors of human trafficking with a lens and intersection of human trafficking, domestic violence, and sexual assault, or in the context of sexual assault and domestic violence. And also identify potential partnerships to support survivors of human trafficking, explore strategies to enhance collaboration, and also utilize resources that will be shared during the webinar and afterwards. And so now, also, we would like to highlight the importance or agreements during the webinar. And the next slide, please. And that is because of domestic violence and sexual assault and human trafficking are so prevalent, we assume that there may be survivors among us in the group participating. So please be aware of your reactions and take care of yourself first. Respect confidentiality, and also please do not discuss any cases that may might be working on, or that may share information, specific information about it. And so now I will turn it over to Katie. Thank you, Katie, who will start with the webinar.
Thanks, Monica, and everyone else from Futures who made this happen, as well as our interpreters. Couldn't do it without you. Okay, so Monica already introduced me. I'm just going to get started. We wanted to start first talking about human trafficking and how it intersects with other oppressions. Because when you work with trafficking survivors, or really sexual assault, domestic violence survivors as well, all of those victimizations surround power and control and the exploitation of people, which so does oppression. So you're going to run into intersectionality. You're going to work with survivors who are experiencing human trafficking and racism, human trafficking and transphobia, human trafficking and, right? All the ants. And that'll make movement through the justice system or the social services system even harder for those individuals. There will be considerations that don't exist for cisgendered white people that do exist for others. So we just want you to be cognizant of that and kind of think through that. The anti-violence against women movement was also born out of the civil rights movement. So a lot of movements took their cues from that movement, learning how to organize, learning how to make an impact, how to pass legislation. All of those things were born out of the civil rights movement and the feminist movement. We know that victims are often targeted for trafficking based on their marginalization. So they might be seen as more vulnerable or easier for traffickers to exploit, or again, less likely to seek assistance because we know that it is harder to navigate the justice systems in that way. For instance, we had a trans survivor in our shelter recently who we're from rural West Virginia, not a lot of cultural competence around here, still a work in progress. And we had a trans client in the shelter who was gonna go seek employment, needed to get a job. And we really had like a whole team involved in coming up with safe spaces for her to apply for, places that we thought or knew of that might be safe. These are conversations we don't have for cisgendered clients. So just keeping that consideration in the back of your mind, and that trafficking is rooted in the interconnected systems of oppression and inequality. So think about that when you're hiring staff. How are you recruiting? Where are you recruiting? Does your staff look like the people that you serve? Do you have equal representation? Are you intentionally diversifying your staff, your printed materials, your website? If you're making educational handouts or you're hosting a training, how are you making that diverse? How are you representing the people that you actually serve? How are you talking to your staff about how the service system can be re-traumatizing? When's the last time you did a training like that? How do you actually work through that? So just kind of keeping all of that in mind as you move through providing services to victims of human trafficking. And I will pass it to you, Erin.
Hi, everybody. I'll just echo Katie and say thank you for this opportunity to Futures. So we really wanted to highlight the interaction, the comorbidity between human trafficking and substance use. Certainly in Vermont, where I am from and work on human trafficking, the percentages are very high of comorbidity between folks that have been trafficked and also are in addiction or using or misusing substances. And that's not a coincidence. There's a lot of reasons why those two things go hand in hand, especially in environments that are rural, like some of the pockets in Vermont that have a lot of hotspots for human trafficking. So what we know is that traffickers can use substances to recruit because substances become an easy mechanism for force and coercion. And they can use substances also to control a survivor or a victim once they're in trafficking by moderating and mediating using addiction as a controlling mechanism. The third way that it might interact is that often survivors and victims of human trafficking need to cope with the experiences that they've had. And so I've worked with a lot of women that say they didn't come into trafficking using, but that it was an emotionally painful experience that was traumatic. And in order to numb and continue to survive, they started to use the substances that were given to them. So there's a deep interaction and comorbidity between substance use and human trafficking. And Katie and I are going to talk a lot today during this webinar about how collaboration across teams is the best way to serve somebody that's experiencing both of those experiences. And we know that adverse childhood experiences increase the risk of opiate misuse and overdose later in life. We are experiencing a huge epidemic of opioid and misuse and overdose in Vermont. And many of those women that we've lost have also had histories and or present moments of human trafficking. And so we know that very often this might not be their worst trauma because they may have experienced many traumas as early childhood experiences. We're going to drop a link in the chat that you can do your own research and education about human trafficking and substance use in your community. The best possible thing is to better understand the specifics of what is happening around you in your community so you can be prepared with education and information rather than anecdotes and stories. It also helps to break the stigma when we know what is really happening so that we don't profile or guess or assume somebody's experience just on our own misinformation. Next slide, please. We wanted to highlight the importance of coming toward a survivor of trafficking with a trauma-informed perspective. And for those of us who've worked in the mental health world for a long time, this is a cliche statement that a lot of people think that they understand when somebody else is using that term. And so we wanted to better define it the best we could. And so we thought about what it means to be trauma-informed when you're interacting with a survivor who's maybe both experiencing substance use and human trafficking. Most importantly, we want to encourage all of you and us to be reminded that we have to meet a person where they are in that moment. That means that we don't bring with us our own opinions and thoughts about where they should be or where they could be, but rather to accept them where they are in their own trajectory of recovery. And we can do that by offering relevant stage-based support, meaning we keep showing up and we keep showing up with non-judgment, meeting them where they're at, regardless of where they are in their process. We want to be trauma informed by advocating for the survivor or the person when they request it. There is a phenomenon in human trafficking, which is what we call rescuing, and it's not actually effective. So we have to advocate for a survivor or person when they're empowered to request it and when they can accept it and when they want help. It's trauma informed to ensure that all of our policies and practices, all of our interactions with survivors are not exploitive or coercive. It is very easy to exploit and coerce through systems, somebody that already has that experience. And so we want to be extra cautious, extra careful to be trauma informed. We always want to offer choices and options. We need to prioritize food, water, clothing, shelter, love, and belonging first before we impart any of the treatment requirements or recovery requirements or court mandated requirements or medical requirements. Folks need to feel safe first before they can start their process of making choices. We want to honor the survivor defined needs and solutions. That's trauma informed is centering their desire and their needs. I've been working in trafficking for a long time, and I've often seen new people come into the field and try to make sure that their survivors do what they believe they should be doing. And the survivors sometimes don't continue that relationship. So we need to provide a lot of choice to be trauma informed. And we also need to take a matter of fact, data-driven, clear and succinct and fact-based approach to substance use, because there's already a component of human trafficking that sometimes people are voyeuristic about, and we want to be extra careful if we're being trauma informed not to be invasive and intrusive by looking at folks as what we believe they are. We really want to ask them about their own story and let their voice be the most important thing. Next slide, please. So we spent some time talking about what we most wanted to talk about with needs of survivors. And these are the needs of our survivors that experience both substance use and human trafficking that we're trying to collaborate around and with. And so it is critically important to be prepared with accurate information about risks associated with drug use and make yourself available to talk it through with survivors. We try not to talk at survivors. We try to talk it through with them about what the might be of different choices. And we try to do that in a non-judgmental, compassionate, kind, caring, empathetic way. We want to put survivors, mitigate so we want to give them as much information as they are ready to have in order to make choices. We want to give them resources, and first and foremost, and heal. Accurate information is critically important, and clarification on the limitations of the systems so that we're preparing them for what they're going to face and meet when their services are broken. We want to partner with and not overpower. And so I'm going to turn it back over to Katie.
Okay, thanks, Erin. You were going in and out a little bit, but I think we caught most of what you said.
Katie, I'm sorry about that.
It's okay. We got most of what you said. I think it's all of our internets, right? It's amazing it wasn't mine this time. We'll see. We'll hold our breath. So we kind of just wanted to open a question up to the group. You can put your response in the chat if you want. What are your values and intentions when it comes to supporting the survivors who also use substances? So like, what are your intentions? What do you come to the table intending to do? So I'll give you guys a second to put that in the chat while we switch to the next slide. Harm reduction. I saw someone say harm reduction. It's a great segue. Promote safety, harm reduction, making them feel heard and cared for, feeling safe, empathetic and support, non-judgmental, compassionate. Oh, you're typing so fast now. Similar things, comfortable and open, be a safe space, start with what they want, be empowerment focused. We like that word around here, named a whole program after it. Recognizing them as humans, love it. Find out what they need and help them anyway. Not re-traumatize, great answer. Yeah, so it sounds like we all have great values and intentions. And some of you have already hit ones we're going to talk about. Honoring each person's wholeness, right? Whole self. I heard one time when I was co-presenting on a different webinar, I heard the other speaker say that survivors will often use substances to feel joy. And I don't know why that was revolutionary to me with the way it was, she said it, like it just, I just had sort of never thought about it like that. So I want you to sit with that for a second, like using substances to feel joy, because we've heard, you know, coping, true, using them to fit in, to have a community, certainly true, but to also feel joy. And I think that's really valuable, right? And I think that's really, it really sits with people when you talk about it like that. We want to offer trauma-informed and culturally responsive support, right? Which we're just learning about now. We're talking about that now. Honoring the dignity and choice of survivors who use drugs, right? They deserve respect and dignity as well. Avoiding re-traumatization, somebody got that bullet point. Present and use non-judgmental stigma skills, 100%. So coming up with little ways to do that, little ways to be present, treating it as a matter of fact approach, and truly like understanding that if we create a program in which survivors are forced to hide their substance use, they will be more likely to not only do it, but also do it dangerously, right? Do it in secret, maybe not tell you if they have no access to a clean syringe that day. But if you've created a matter of fact, open door approach, as soon as they walk in your building, whether that's a shelter, transitional housing, outreach, whatever you do, no matter where you are, if you approach it as open door, matter of fact, they will be much more open about their needs surrounding safe use, surrounding use in general. We have taken that approach. Our shelter is over 40 years old, but I've only been here for 10 years of it. And probably only in the last 5 or 6 years, 4 or 5 years, did we really fully understand how to do this better. And just in the last 2 years, where we've really instituted a harm reduction approach in the shelter, we have had such genuine conversations, to the point where like my abuser, my trafficker is my dealer. And that's a complicated relationship. How do I, stay safe, but also access my substance? It's a small town. Everyone knows everyone. My dealer knows my trafficker. Like, you're going to have these really intense conversations that might scare off advocates at times, but it based on how you train them, right? So train them to expect that, train them to work through that. How do you safety plan under that setting? Keeping connected and caring, right? Remaining connected to the survivor, to the services, to the community, and creating a no wrong door approach. So it doesn't matter how they access you, it's the correct door. You are in. You're in our services. We've got you. You can go to the next slide. And so moving into collaborations, we talked about, Erin touched on how collaborations really help us serve survivors in the best possible way, because we know we can't do it all on our own, right? The shelter can't do it on their own. The hospital systems can't do it on their own. The justice system can't do it on their own. We all need each other. And creating a no wrong door approach across collaborations, truly instrumental. So we're better and we have stronger collaborations when none of the programs screen out for substance use and programs create a safe space to talk about substance use. So what does not screening out look like? Don't ask about it, right? When I first started in victim services 10 years ago, that was a question we had to ask. Before we could let someone come into the shelter, we had to ask, are you currently using substances? And if they said yes, we would say, oh, we don't have any beds available. Did that hurt anyone else? Did anyone? I feel like I can't see any of you, but I feel like everyone just flinched, right? Everyone just shut the computer and walked away. Yeah, ouch. Yeah, that really happened. I remember it. And that's not it, right? That's not how we do it. What we've come such a long way since then, but one of the things that we've done is we train all of our staff on the stages of change model. So pre-contemplation, contemplation, ready to make change, taking action. And that has been super helpful in just sort of understanding where people are when they make comments about change, around substance use or not, right? General comments around change. That's been really helpful. It's also been really helpful to include a section on substance use, physical health, mental health in our basic case management outline. So it's something we talk about with every single client, regardless of if they've ever brought it up. And if they want to talk about it, we do. If they don't, we keep it moving, right? So just treating it as a service, not as a barrier to service, if that makes sense. You can go to the next slide. And then we also want to shift when we're working with trafficking survivors, particularly those that use substances, from rule enforcement to just coming alongside as a collaborator. So get rid of that power dynamic. One easy way to do this that we did here for any management on the webinar is we basically eliminated a dress code. So that's not going to be possible everywhere, right? Like your advocates still have to go to court. hospital settings, you obviously can't eliminate your dress code, but it was really helpful in the shelter setting. That's one small way to eliminate a power dynamic, an unintentional power dynamic, right? You got staff showing up in three-piece suits that creates immediately an unintentional power dynamic. So we essentially have no dress code, except obviously for court, and that's been instrumental in helping to eliminate stuff like that. Minimizing your rules. Take a look at the rules. Are they necessary? We don't have a single rule in our shelter. We don't have a single one. We call nothing rules. We have rights and responsibilities. So for instance, you have the right to live in a safe, clean home. Therefore, you have the responsibility to help keep it clean. How does that look? That looks like these things, right? These sort of household things that get done. Now, next question, survivor doesn't do the chore, doesn't do the cleaning, doesn't do the thing. That's not a reason to lose housing, right? So adjusting your rules to really focus on how do we create a welcoming environment where everyone still, holds a piece of the pie, but we're not threatening housing over it. If you've ever heard of the article, How the Earth Didn't Fly into the Sun, it was surrounding a domestic violence programs that did a study on eliminating rules, and you would be surprised to see how well they did after getting rid of rules, particularly surrounding, we also don't have a curfew, and that blows people's minds. We also don't do room searches. So there are ways to, the name of the article was How the Earth Doesn't Fly into the Sun. It's I don't know why they named it that. I feel like, but it's a good one. You should read it. Behaviors that pose safety concerns are approached with empathy. So rather than you knew that would cause danger, why did you do it? What brought us here? What caused this, right? What's happening? What's going on? You haven't been here in 3 days. You okay? Have you been staying somewhere safe? Sort of like what's, instead of, the rules, you haven't been here in 3 days, right? Creative solutions that you craft without fear of punishment. So lessening like the 3-strike rules, not helpful. So more like, let's come at this problem together. So here's this barrier. How do we stop the barrier together? What is it going to take, right? What do you need? And people are actively invited in their own safety. I remember one time having a conversation in the kitchen of our shelter with a couple staff members, and there were clients, around too. And I said, I really don't understand what to do about this dark area of the backyard. There was like a dark area in the backyard. And we were pondering it, and we've been talking about it for months. And one of the clients said, why don't you just get motion censored lights? And I was like, oh, why don't we just get motion censored lights? Like, what a great idea. So partnering with survivors surrounding even the operations of the shelter, the operations of your harm reduction program, the operations of your task forces, right? Like, how are we collaborating not only with our partners, but with our survivors that we're fighting this fight with every day? I will move on to you, Erin.
Thanks, Katie. I hope my connection is okay. One of the things that you heard from Katie that is so important in collaborating with survivors is creativity and adaptability, and thinking outside the box. And the same way that we want to bring lots of different disciplines to the table when we're creating teams, we want to view our survivors as holistic and multifaceted folks that are not their trafficking experience. And in order to do that, we have to have lots of different voices and opinions, specifically, and most importantly, the survivor's voice, but also the front end voice, the treatment voice, the harm reduction voice, the recovery voice, the advocacy voice. All of those are important when we're trying to deliver to a survivor an option and an opportunity to make a different choice. And so we have to collaborate to do that. We have to work with a lot of different types of folks. And in Vermont, we have been working on collaboration quite a bit. And so we want to bring medical service, we want to bring peers to the table, we want to bring mental health service, we want to bring education, vocational, legal, childcare, family. We want to bring a lot of different people to the table to fill these buckets of prevention and treatment and harm reduction and recovery. And part of that is having the different disciplines and beliefs and values, but part of it is also that survivors of human trafficking feel differently around different types of people at different parts of their recovery. And there's been a lot of experiences where I've been working with a trafficking survivor and I'm not their person. And so I have to get a person for them. And then that's not their person. And that's not their mechanism for recovery. And so it's really important to be creative and adaptive. Partnerships can be fostered between healthcare and other service providers, including those who work in domestic violence, in foster care, in law enforcement, and others. And the most important part about that is that communication mechanisms and policy alignment can also be enhanced to bridge those gaps from different disciplines so that the social service agencies that deal with women and families can improve the treatment approaches and outcomes to provide better opportunities. Next slide, please. I train a law of harm reduction, and it is critically important, as Katie said, to give our staff and our community the opportunity to see a different alternative to zero tolerance. And it is so important in human trafficking because in doing this for many years, I've seen a lot of women recover by titrating down off trauma. And that for me means that they're working their program, their own personal process, and getting safer and safer and safer and reducing risk over time. And that's not an overnight thing. Nobody can do that. I can't do it. Nobody on this call can do it. And so we have to understand that meeting somebody where they're at is a harm reduction strategy where we connect individuals to education, counseling, and referrals. We do the type of thing that we wish somebody would have or could do for us if we were trying to get out of a risky or unsafe situation. We do distribute opioid overdose reversal medications. We do train the community on them and how to use them. We do train our people on how to do them and how to use them. We lessen harms associated with drug use that increase the risk of infectious disease. We're talking in Vermont about safe injection sites, finally, in my opinion. And it's really important to try to create and build adaptive and alternative solutions. And part of what we were seeing in Vermont is that perpetrators of trafficking were coercing their survivors and victims to only take injection from them. And that was creating a very complicated relationship. And so we have to empower our survivors to reduce their harm over time incrementally at their own pace with their own tools. We do facilitate capacity building for service providers to provide support with the use of medications. We do need to train and educate of what is harm reduction and how do we apply it smartly and utilize it in a way to give people the very best chance. Next slide, please. So we want to do a little poll, and we want to know from all of you, what are some of the strategies that you are using to address human trafficking and substance use? If you check other, just chat in the chat box what your other is. But we're curious, are you using services? Are you using protocols? Are you using harm reduction like we just talked about? Are you using collaboration policies? Are you using MDTs? Or are you using something other? And again, if it is another, we are so curious about what it is. Because there are a lot of ways and strategies to combat human trafficking and substance use. And it's different in different areas with different leaders and different teams. Before we find out what happened in that poll, we just want to highlight and remind you that strategies can be general and overarching, like statewide policy or statewide practice, or national practice and policy, but it can also be super specific to the area, like treatment for pregnant women who are experiencing trafficking in substance, access to public housing for women on methadone. Those are specific examples of services that you may be putting in place for strategy. Katie, are we seeing a poll total? I'm not seeing the poll total.
I didn't see the poll total either.
There is some, yeah,
yes, this is Monica. We have responses.
Oh, great.
And I think we can share them now. We have services, harm reduction, collaboration policies, multidisciplinary teams. Everything is in here. All the strategies that you all.
Oh, there it is. Okay, so I got it, Monica. Thank you so much. So 71% of you all are using services, which is great and interesting. 20% are using protocols. 55% are using harm reduction. 39% are using collaboration. 37% MDTs, and 3% other. And so to me, that means that we may have hit some of the high percentage strategies, but there might be something specific to your area that is a niche need that you are strategizing around. Next slide, please. So we wanted to talk about building your team. And this is something that I think about as the co-chair of the Vermont Trafficking Task Force all the time, which is, who do we bring to the table? Who wants to be at the table? Who wants to be at the table for the right reasons? How do we create a space at the table that is victim-centered and or survivor-centered and is in alignment with all of the things we know about what Katie was talking about earlier, which is that certain populations of folks are more likely to be oppressed and trafficked and traumatized. And we have to come from a perspective of educating ourselves in order to be at the table. And so first and foremost, we wanted to say that the most important thing about how to build a team is by building the team voluntarily. And in Vermont, we started building the team 10 years ago by people being told that they need to work on human trafficking. And we've lost a lot of those people at the table because they're not motivated and passionate. But what has replaced them is folks that have heard about trafficking or worked a case and fell in love with the resiliency and the resourcefulness and the creativity and adaptability of the person, and are dedicated and committed. And those are the people that we want to put at the table so that they stay and impart their knowledge over time and continue to show up over and over and over. We want to make sure that the team lead is organized and experienced. And that means that they understand the intricacies and the subtleties of human trafficking as it relates to the difference between law and statute and actual presentation and treatment and recovery and all of those things. It's all complicated, and we need somebody to lead us that understands all of those complexities. We want to ensure representation from substance abuse services. We made that mistake in Vermont for a while, and that we didn't have substance abuse at the table, and a lot of our survivors were experiencing substance abuse and we were missing it. And so we want to have the folks at the table that specialize and have expertise in their specific area of the intersectionality. And we want to define communication and collaboration guidelines so that not only do we bring the right people to the table and we lead them in the right way, but that we also ensure that we have mechanisms in place for helping them work together across discipline, across beliefs and values, and across experience, so that survivors get the very best that we possibly can give to them. And communication and collaboration is key. Katie, you want to take this next one?
Absolutely. So you're starting to build your team, right? Here we go. Make sure to center ongoing training and education. It feels like we'll talk about West Virginia's team origin in a little bit, but it feels like since the beginning, we have trained and trained and trained and trained and trained. Team members, community members, everybody. Training evolves, training needs evolve. And there's so many like micro pieces of it that you can train on, like intersectionality and human trafficking could be a whole event by itself. Rural trafficking compared to urban trafficking, like there's so many pieces. Know that when you're creating your team, a diverse team is both going to be challenging, but also an opportunity to make change. So we had in West Virginia at times, and as a state and as little local task forces, county task forces, we've run into people being members of the team who might think that all survivors should report to law enforcement. And we've had to have those discussions that that's not for everyone, right? That that's not the safest mechanism or the healthiest mechanism for all survivors. And working through that as a multidisciplinary team is so much better than everyone just being in their own funnel and thinking what they think and believing what they believe, right? Get to know each other, make it fun at times, do some icebreakers. We know we think they're corny, but they can sometimes be fun. Build trust and connections so that when there is a thing, right, there's a survivor who needs something, or there's a training need or whatever, you have this whole team of people who trust and believe in you that you can call on to help. And then move as quickly away from human trafficking as an add-on to it being the center of what you're doing on that task force. And Erin, I didn't know if you had anything, do you have anything to add?
I would just say, I agree with what Katie said in West Virginia. In Vermont, no matter what else has paused regarding human trafficking, training and education subcommittee and work group has continued. We've continued to educate the entire time, and it's critically important to educate the team as well as educate the community and educate the survivors.
I agree fully. You can go to the next one. So when you're working collaboratively, it's important to make sure that you're placing the needs of survivors in general, but survivors who use substances as well, in the center of the team. So if, for instance, a survivor is entering the team as in receiving services from the team, so maybe there's an advocate and a prosecutor and a law enforcement officer and a forensic nurse all working with the survivor, it's important to place their needs in the middle, not the needs of the systems, right? Not what makes it easier on the systems. Allow the survivor to choose their contact person if they can. Did they bond with the forensic nurse when they were going through that process? Is that who they would like to be, communicating with the most? Is that possible under your current structure? If not, how do we make as many adaptations to that as possible? Information and safety first. We've all heard this working with survivors across all of the victimizations, but giving back choice is important in whatever setting you can do that in. Expect the survivor not to necessarily trust you, any of you, right? In the beginning. Be honest about the limitations of services available. So in West Virginia, for instance, our Victims Crime Comp Fund requires that the survivor had report to law enforcement within a certain amount of time. So if that didn't happen, or if they don't seem to want to report or whatever, be very honest about limited resources like that. So for example, you could say, in West Virginia, this is what the Crime Victims Comp Fund is. This is what it requires of you. Kind of where are you falling along that line? What are you feeling? We know that there's limited resources, particularly in rural areas. So be very honest about that, right? Don't sugarcoat what's out there. Don't sugarcoat what your team can do. And don't share information that you don't have to share. When I train my new staff, I always say, as a joke, but I always say, this is not an episode of Criminal Minds, right? Don't ask questions just because you're curious. You don't have a right to information that you don't need to know, right? For the job or for whatever you're doing. And then make sure you're not sharing information. This is not, it might feel like a good true crime story to tell, right? But it is not your true crime story to tell. So don't tell it in a voyeuristic way, just to kind of hit the punchline, right? Which is something we've seen come up in training. When people were training, we've had to talk about how to share stories in a respectful way, as to not just get like the shock, the all effect from people attending the training. Okay, you can go to the next one. Making sure that your services, no matter what point of entry they're coming into your collaboration, are accessible. So do programs allow over-the-counter medication in shelters? And not, we've already talked about this, not declining services for those who use substances. How do you navigate that? One thing we found to be really helpful in our shelter is that we provide everyone with a locked locker that will not be searched. So something that we might say upon intake with a survivor is, if you have anything that you really want to keep safe, you can put it in your locker. So if they put, their substances in the locker locked up, would 10 out of 10 rather have that than have it stored under their bed, right? Which is what was happening before, and probably what's still happening sometimes. Another trick with over-the-counter medicine that we found, because in a lot of states, it is not legal for advocates to dispense medication, I say in air quotes, which could even mean just like giving someone Tylenol. So what we found is that when we ask for donations, we ask for small bottles and we give them the whole bottle. So it's like, this is your Tylenol now, right? Demonstrate that you're willing to work with survivors who are using drugs through material, language, and narratives. Talk about it openly. When you go present at your Chamber of Commerce or your Rotaries or your whoever, make it known. Like, we serve all survivors, including survivors who struggle with substance use disorder or who use substances. This is how we've adapted to that. This is how we make it work. This is how we provide adequate services. This is our whole team right behind us who supports and upholds this work. Be inclusive to all people. How do you make sure that the general public knows that you're inclusive to trans survivors? For one thing, I know this is, it's 2022. I hope most of us have done it, but there are domestic violence and human trafficking and sexual assault program names that still have the word women in it, right? So change your name. If you want to change your name and it feels overwhelming and daunting to you, I can help you. We did it. Just email me. You'll have my contact information. We survived. We're 4 years out. No one forgot about us, right? Our former name is Shenandoah Women's Center, but you'd never know that now because we switched it. Make sure you translate your materials and you have proper interpretation services available. And make sure your staff know how to access them. That's been a mistake that we've made before, where we didn't really include it in new stuff. We were just like, oh, we have interpretation services. We didn't tell them how to use it. So then we had no idea, like in the time, right? You don't want it to happen in the moment. And consider the unique needs of survivors with disabilities, particularly if you're operating out of a 1970s shelter like us, where our shelter is way too small, not built to be a shelter, and the struggle to make it accessible has been real. But really dedicate the time to look into that. How do you do it? What do you need? Bring in a consultant. What does it take? You might even find that you have local consultants that would do it for free. You could also make it known in your job postings, in your things that just people might read about your organization. If you're in a newspaper, if you're on the radio, just mention it. Also be involved in the months, right? The stuff. So make sure that you're very loud, not only during Pride Month, but every other month of the year. Make sure you're very open during Hispanic Heritage Month. Make sure you acknowledge all of these things as they come, and then keep that consistent message all year round, right? So that it's kind of like impossible for people to know. For example, this just happened to us today. We operate in a rather small town. It's a big town for West Virginia, small town for the rest of you. And our local library decided that they wanted to educate their staff on LGBTQ needs issues surrounding, what their customers might need, anything like that. And they decided their first thought was to call us. They were like, who can help us with that? Epic. even though that's not, we're a domestic violence, sexual assault, human trafficking organization, but we have branded ourselves as such that they know that we're a safe space that they could ask for help in navigating that with. So just make sure that it's so obvious that no one ever has to wonder where they could go to get services from you or assistance for their staff, just like something like that. Back to you, Erin.
Thanks, Katie. We wanted to give you a snapshot of both of our states and how it relates to what we've been presenting to you. And so in Vermont, the majority of the adult human trafficking cases have a drug component. However, I want you all to know that we have not done a good job in Vermont at gathering data as it relates to substance use and human trafficking. In fact, the data that we've gathered was specifically in order to begin to apply for funding in 2017 and 2018. And so we pushed hard to start gathering data on victims and survivors of human trafficking across the state. And at that point in time, we didn't understand how related substance use and human trafficking in Vermont was. And so we didn't go after those pieces of the data. However, when you look at all of the survivors, about 90% or more have a substance use related component to their experience of trafficking. Similarly, in the youth cases, specifically in the older adolescents, there's a large drug component, anecdotally more than 50%. And combine that with the other thing that's happening in Vermont, which is that we don't really have a substance use continuum of care. What we had before the pandemic, we don't have anymore. And so we don't have any adolescent and teen beds, and we don't have any adult beds that specialize in human trafficking, or even the ones that we've trained, those staff members and employees and personnel have turned over. And so there really isn't a pocket of detox or rehab treatment for adults in Vermont that have any specialty in human trafficking. And so the numbers are high and the opportunities and offers are low. And so we've had to be incredibly creative about how to offer recovery to the survivors of human trafficking in Vermont. Next slide, please. The substance use component in someone's human trafficking experience adds complexity, which we've been talking about, and complication. But in Vermont, we've seen that it adds substantial complexity in terms of timing and readiness, because as I said just a minute ago, we don't have the offer that we need. And for those of you who have been working with survivors for a long time, you know that there's a window that opens and then closes and opens and closes. And for some people, that's a very short window of opportunity. And so timing and readiness is critically important. And in Vermont, we don't have the continuum that we really need. And so that requires a team that works together very, very rapidly to resource options. And as I said, treatment availability is very, very nil. Especially the high end of substance is very difficult and challenging in Vermont. And historically and to date, I have been reached out to numerous times for consultation on mostly 19 to 26-year-old women who've been asked to leave their treatment environment because of behavior, which is for a trauma person, for somebody who understands trauma, it's a symptom of their psychological trauma, and or substance use. And so when you have both human trafficking and substance use in Vermont, there have been many times where the survivor has been asked to leave. Next slide, please. And so really quickly, this is the trajectory of our history, which is that in 2010, we built some very progressive laws, but before that, we had not any laws. And so we have a lot of statute in Vermont to protect survivors and victims of human trafficking. And in 2017, using VOCA dollars, they created 2 case management positions, a northern and a southern. In 2018, we got the federal collaboration grant, which really encouraged law enforcement and victim services to work together to achieve the deliverables. And in 2021, we subgranted the rest of that money of that grant to build 3 pilot MDTs in districts that are experiencing a lot of sex trafficking and sexual exploitation. And in 2022, we are repurposing the Vermont Human Trafficking Task Force so that it no longer has an authoritative outreach statewide, but rather puts the money and the services back in local districts, which is the better approach for the state of Vermont. Next slide, please. What we've learned is that traffickers and trafficking networks are usually one step ahead of the collaborators, that the pandemic broke some of our continuum of care and has made staffing shortages increase collaborative barriers and made the teams that we've built stronger at communicating quickly and finding solutions rapidly, because it's not very easy. Housing is an enormous barrier, which is compounded for survivors of human trafficking with substance. And we have to come from a survivor-centered place if we want to continue to push forward and build best practice community opportunities. And communication and trust is the most important component of a human trafficking team. Katie?
Okay, so West Virginia. Our West Virginia task force was originally paired, like it was just sort of added on to the hate crime task force that was run out of our U.S. Attorney's Office, but broke off on its own around 2015. And we also had terrible human trafficking legislation on the books at that point. In order to be charged with trafficking, you had to traffic 2 or more people within a 6-month period, which we all know that there were no convictions under that statute, right? As soon as we heard it, we were like, that didn't happen. We changed that law in 2017, but it took a lot of blood, sweat, and tears to get there. We have a much better legislative response to trafficking now, but that was a whole event. Our task force has multiple subcommittees. We have a law enforcement subcommittee, a victim services, a grants, a data collection, and a training. The 2 that I have been most involved with are obviously victim services and training. I co-chair the training. The grants subcommittee has been slow moving. We don't actually have a lot of human trafficking grants in West Virginia. We don't get a single one at EPIC right now. We do all of this with other like VOCA grants, other grants that allow you to do trafficking work, but aren't necessarily for that. So being underfunded has been a problem of our task force since the beginning. You can go to the next one. We struggled to keep attendees interactive and returning. When the task force launched, I am an original member, so I've been with us since the beginning. When it launched in 2015, we would have 50, 100 people show up, which is a lot for a population small state. We're not really geographically that small. And we started really big, and we had to scale down to get the most invested and involved. And we ended up with a dedicated group of people who understands each other's disciplines and works across those disciplines really well, but we're not always there. We had a lot of attendees. We struggled a lot in the beginning. So one thing, if you're just starting to collaborate, that I would give as a tip is to create space at the beginning of most meetings, particularly in the first couple of years, to catch up people who may have never been there before. So we would be started in on a conversation around, would like to say, like, I remember this one distinctly. We were talking about labor trafficking in Appalachia, kind of in general, and what that looks like. And I will never forget, we were like 45 minutes into this really deep discussion, and some poor person raised their hand from the back, and they were like, "What's labor trafficking?" And we were like, "Oh, whoops." So make space to kind of talk about the 101 stuff, even if you have to make your agenda a little bit longer. We struggled significantly with people across the state doing trainings that were not accurate or trauma informed. And a response to that was that we did a set of regional trainings. So we created a core training team. It was like the same 6 trainers. I was one of them. We had people from different disciplines. We had like a law enforcement officer, we had a U.S. attorney, we had state prosecutors that advised us, we had CPS involved, and we would go from location to location doing the exact same training over and over again, so that we really controlled the message, right, that was getting out to our first responders, what trafficking is, how to approach it, how to help. We had a lot of differing ideas, still to this day, a lot of differing ideas on how to address substance use. West Virginia has passed some pretty harmful legislation, in summary, but specifically around harm reduction. They actually made the exchange of syringes essentially illegal, clean needle exchanges essentially illegal. There's a way around it, but it's very difficult, right? Which was the intent. So just the whole harm reduction conversation has been hard but necessary within the task force. So I would encourage everyone to have these conversations, even if they're hard. And that legislation still stands. And our programs have just figured out ways around it, ways to not violate the law, but also to still help survivors. And that has been difficult, but worth it. So if you have a similar policy in your state, I would encourage you to still press forward. There are ways to make it work through collaboration, right? Keyword. Okay, you can go to the next one. We did within our task forces, another thing we struggled with was okay, we've identified a survivor. That was step 1. Now what do we do? So we created a referral flow chart for first responders. So it's divided into 2 pieces, if it's a child and if it's an adult. Do they want to report? What does reporting look like? Who do they report to? We dedicated a single referral line for cases where they wanted justice system involvement. So we have like one sort of like police barracks that you call, who then disseminates that information out to relevant sources, relevant area sources. We advocated for better legislative definitions of human trafficking. Like I said, that was a whole event, but it passed. And we have been doing it and been training on it. And our multidisciplinary team. And those regional trainings went in person. We did them in person. This was pre-COVID. And then during COVID, we did a series of webinars to kind of still keep people involved and still have them hear from the same trainers. We also then, as a training team, developed a training of trainers that we have done twice virtually. Never even gotten to do it in person because of COVID. But that team trained other trainers to then use the same curriculum. So what we were seeing were varying curriculums that talked about trafficking in ways that weren't necessarily true. For instance, Erin mentioned this earlier, we would see the rescuing people conversation occurring a lot in training, as we were like, that's very dangerous. We would see nothing about cultural competency or nothing about intersectionality. Again, very dangerous. So we wanted to lay out a curriculum that was accurate and that we could teach people to train. So we've done 2 rounds of that. So we're up to like 20 certified trainers, certified. We don't really have a certification process, but in West Virginia now. Regionally, it's much better. It used to be, there was a long period of time where a training request would come in and there were like 2 of us that could train on it. So I would be going to like the southern part of the state. I'm in the northeastern part. I would be driving 6 hours just to do a 2-hour training and then drive back because we didn't have anybody else to do it. But now we just got a training request that came through from the southern part of the state and like 8 people responded. It was like, I can do it. And I was like, this is better. So I would highly suggest that as to not wear out your trainers. Oh, it's okay. So, okay, next, rural. So West Virginia is a rural state. I'm sure a lot of you are also from rural states. So there's some considerations that are unique to those living in rural areas. Transportation is a barrier 10 out of 10 times, every single time. We have one county, we serve 3 total counties. We have one county that has absolutely no public transportation, and 2 more that have very limited public transportation. So look at your grants. Can you buy agency vehicles? They're not that hard to operate. They're not that hard to manage. Super helpful. have dedicated staff that drive clients to and from work, and make sure that if you do offer transportation services, you're offering those services equitably. If you're going to drive someone to their cardiologist, you need to drive them to their Suboxone appointment, right? Equitable transportation services across the board. We've just a significant lack of resources, right? And lack of treatment. Know what is available and use it. Become really good friends with those people, right? If there's one single substance use treatment program, they should be your best friend. And they should know you when you call them up. Know exactly what they do. Everyone knows everyone. Boy, oh boy. That's the most true in our most rural county. We have one county that's particularly rural. Stress with your staff what your confidentiality guidelines are. Make sure everyone knows it. They could recite it. What do they say when they're asked to violate confidentiality, particularly in like MDTs, other multidisciplinary team meetings that might not be your task force, but then also your task force, right? How do we maintain that on our task force? And we have areas where culturally specific programming is not welcome. And that is a battle we fight every day. My advice, if you're going through that, if you're working through that as a team, is to be very specific in who you hire. Be very upfront. So when I'm interviewing someone, I will say, these are the values of Epic. Do your personal values align with that? Right? So like you're getting it out the bat, because if you have a whole staff that agrees, your work's going to be a lot easier. And then just be very upfront in your community. This is what we stand for. This is what we believe in. We would really appreciate your support. And the same on your task force, right? The same when you're collaborating, whether it's with your community or with fellow task force members. All right, Erin, back to you.
We wanted to take a minute just to highlight the risk associated with working in the human trafficking field. And before I tell you about the risk, I also just want to tell you that the reward is far greater than any risk as long as you take care of yourself. And so you can't have the reward if you're not managing your own wellness and well-being. And one of the ways that we do that is in Vermont, we consistently talk about compassion fatigue and vicarious trauma and what they actually are and how they look in all of us in different ways, so that we can, as a trusted small team, talk to each other about how the other is feeling. And so becoming trauma informed with survivors or clients begins by recognizing our own experiences with personal and vicarious trauma. And it is normative and it is expected in human trafficking work to feel fatigued, frustrated, sad, disappointed, all of those things, exhausted. And what we want to be looking for is when those experiences impact our functioning, our professional functioning. And when they start to impact our professional functioning, we really need to utilize and care for ourselves in new and different ways. And we have to think about what our own wellness and well-being plan is in prevention of when we feel big feelings about human trafficking cases. And I have been consulting in Vermont on a lot of the cases since 2014. And I have heard a lot of the stories. And whenever I talk to somebody about somebody that they're serving, I'm always trying to remind them to take care of themselves so that they can be the best possible servant for the person that they're trying to offer opportunities and options for. The work is fatiguing inside a system that is fatiguing alongside professionals that are fatigued, normative, expected, and still your responsibility to take care of yourself so that you can continue to serve. We added some wellness resources. Next slide, please. So that you all can investigate further what we already know about compassion fatigue and vicarious and secondary traumatization. And there's some links there. And also, this is a small snapshot of what has come out since 2006-ish. In 2006, there started to be a lot more materials on how to care for the caregiver. And now, because the pandemic has been so hard, there will be many, 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 many more materials coming out about care for the care provider. I don't know, Katie, is that one yours, the important takeaways, or are they shared?
It's shared.
Okay, you want to go ahead?
Sure. So things we want you to take with you before we answer some of your questions. Trafficking is a violation of someone's right to freedom, and it's cumulative trauma, right? So that's a less intimidating way to talk about it, right? And to start where you train your staff, where do you train your team? That's where you start. Trauma-informed care leads to better services, and your team will function better if everyone operates under that lens. Trauma-informed care leads to better adaptive behaviors. When we train our staff here on trauma-informed care, we always go through all of the ways that trauma can affect a person. And at the end, we're like, and the good news is you can positively affect a person by the way that you interact with them, right? Recovery and rehabilitation depends on the restoration of their mental health and their sense of humanity. So we got to keep that sense of community. We've got to keep that sense of belonging, that sense of joy, develop other ways, figure out what they enjoy, right? Do you like sewing? Buy them a sewing kit. Do you like journaling? Let's have a journaling group. Painting, we'll find you a wall to paint, right? So like just figuring out ways to incorporate joy and belonging. If they're interested in talking about that. All right, you can move on to the next one, which I think is questions. Do you want us to answer questions from the question Q&A, Monica, or do you want us to talk?
That would be helpful. I think this is an opportunity for, I only saw one question in the question and answer, but also for participants to share what so far your takeaways, things that you would like to share, and also things that any questions that you have.
I see 4 questions.
Okay, great.
Maybe I'm only seeing one of them, Erin, I'll just read them and then we could both answer. Do you have any advice for programs when it comes to maintaining safety when someone's trauma symptoms may lead them to behave in ways that threaten others' safety without having to discontinue services? Do you want to start? You look like you know it.
Well, this question means a lot to me because people that are recovering from trafficking don't necessarily recover immediately, and they don't do it sometimes quietly. So that is a discussion that I have with a lot of the programs and we have a restorative justice model in Vermont for harm. And so that is the way that we talk about those choices and how they impact others. And that can look very different in different programs, but we try very hard not to be punitive in the window of time that somebody's trying to learn different choices after a long period of time of not being empowered to do so. And so that's what we talk about in Vermont. I'm interested, Katie, in what you're going to say.
Yeah, in the shelter, we definitely run into this every single day. And my advice would be to treat each individual circumstance as an individual circumstance. Avoid overarching rules or policies. We call them reactionary policies, where you're reacting to a single situation with a policy. So avoid that. Consider when you think it's affecting other people's safety, is it affecting other people's safety or is it making staff uncomfortable? Right. So like really evaluate the behavior and what it is. And then also shelter is not for everyone, right? Everyone cannot live in a communal shelter. So when you're writing your grants, when you're working through your budget, think about alternative housing options. So would someone with really disruptive behaviors do better in a rapid rehousing situation where you instantly rehouse them instantly? Can you prioritize someone like that? Or would a hotel work better for this person? We had a client one time who would really enjoy, when she was stressed, would really enjoy singing at the top of her lungs to whatever music she had on her radio. And that doesn't work in a communal living setting, right? So figuring out sort of how could we give her space outside where she could do that? Like, how do we make it fit with the limited resources that we have? But at a baseline, I would say treat it every individual circumstance as an individual circumstance, which takes more time, right? It takes so much more time and so much more energy. But that's how we help people. Okay, next question. Can I share my training curricula for the state training curricula? I'll put my email in the chat. If you email me, Peg, I will ask, because I didn't develop it all. I can share what I've developed, but I will ask everyone else. We hear some survivors express discomfort with staying in a shelter that allows survivors to actively use substances to stay. Most of this time, this discomfort originates from a concern about triggering past experience with substance use disorder. Oh my goodness, every day. Do you have tips on how to support survivors in substance use disorder recovery in a low barrier shelter environment? Yes. So one thing that we found really helpful is to have groups for both. So groups for people who are actively using and groups for people who are in recovery. And we also flip the narrative. So if they say, I can't be in a room with, well, also we share rooms. We have shared rooms. Nobody has their own room. I think that if our shelter, everyone had their own room, 95% of our problems would go away. But they don't, so that's what it is. So another thing that we found helpful is to be flexible on who shares rooms with who. So we used to be like, oh my gosh, we're so tired of everyone moving rooms around all the time. But we've actually found that if you're a little bit looser and you let them kind of choose their own roommates, they'll choose safely, right? They choose who makes them comfortable. That has been helpful. Another thing that has been helpful is the matter-of-fact approach. And even with other survivors, helping to dismantle some of that maybe implicit bias or explicit bias, right? So talking about, what does survivor use actually look like? What are ways that they could work through a safety plan to prevent reuse, to prevent relapsing, right? What is their safety plan? What do they have? Creating kind of a group has been really helpful. Do you have anything to add, Erin? I don't want to. Okay. Last one that's on this one that I see. When assessing survivor recovery, what questions or mindsets do you like to avoid? You want to start with that one?
What did it say, Katie?
When assessing survivors' recovery, physical and mental recovery, what questions or mindsets do you like to avoid?
I think first and foremost, I'm trying to avoid a mindset that makes me think about whether they would have been more well if they had left sooner. And so I'm trying to think about the way that they are right now and what I could offer them for recovery, rather than thinking about how long they were in it, all of the terrible and awful things that happened. I can guess that there were terrible and awful things, and I don't need them to tell me that on the front end. I try very hard not to focus on what happened in that increment of time during trafficking, and try really hard to focus on the front end of what can I offer right now.
And I would say the savior mindset. They're going to come in with like a scoop and just scoop everyone up and save them. And they're going to come to shelter and they're going to walk in the door and they're going to be so grateful. No, they're not. And no, they shouldn't, right? No one is grateful to live in a shelter. That was one of the first things that it took some time to sort of change the mindset of some advocates who'd done this work for a long time and did it in kind of the old way. Was that, well, they're not very grateful. It's like, no, they're not, right? So I think just this kind of savior complex is a mindset I would certainly suggest avoiding. So Monica, those are all the questions I see in the Q&A. I think someone put one in the chat. I work for a domestic violence shelter that accepts individuals and families. We also have trafficking survivors with us. We try to have a harm reduction model and we don't screen out. However, we do have rules regarding not using substances on the site or being intoxicated in the shelter. Any ideas, resources, or lessons you've learned around navigating, maintaining a shelter environment for children? Yeah, for sure. So West Virginia actually requires us, according to our license, to also disallow substances in the shelter. So we help people come up with other places that they could put it or other places that they could use it that are safe. So that's a conversation. We do allow people to come back if they're intoxicated. And sometimes what we'll do if a survivor discloses that they use, they use alcohol, they use substance, whatever, we will ask them, how do you feel when you're using? Like, what do you usually do? What happens, right? So that we're sort of prepared for the case that they come back intoxicated, and we have a safety plan around what we can do with that, what we can do for them in the building. That's been very helpful. Around having children, it's sort of the same approach. So giving a safe space for where to store the substance, whether that's in their locker, which we wouldn't know about, or whether it's out of the building in their car, at a friend's house, whatever. Because I promise you, having run a shelter both ways, ran it before when we disallowed it, ran it now when it's matter of fact, it's there no matter what. And now we're more aware of what the substance is, where they might be storing it, under what terms they're using it, setting, sort of what their mindset is when they're using, has been very helpful. And then it's also really helpful that if you treat it as matter of fact, when the family comes in, the parent of the family is kind of very aware of what the philosophy is of the program on substances. We have children in the shelter right now, and we have people in the shelter right now who are actively using, and they live cohesively. It's not always perfect. We will address things kind of day by day as they come along. But we just treat it matter of fact, no matter what the resident's age is. Now, obviously, if we have like a crawler, like a toddler, or somebody who really could get into these things, we'll be more mindful of like checking to make sure nothing's there. We don't do room searches, but we do help clients reorganize. We have very limited space. So when it's like reorganization day, we'll help them, which is good because you can help help them manage their stuff. Where are you putting everything? So that's been really helpful. But I would just say treating it matter of fact, no matter the age or the level of use, has been very helpful in keeping everyone safe. I don't see any other questions, but I might have missed them, Monica.
Oh, thank you. Great. Thank you so much for responding to the questions. And thank you everyone also for participating and engaging, sharing your questions and also your resources. And I think we're just gonna go over a few resources and that you have in the handout. We just want to highlight that there are several resources, including recommendations to support survivors with substance use, including one document that is based on the feedback from actual survivors, and also for mental health and substance use support, harm reduction, and other resources. In the next slide, please, we have also a list of other resources on collaboration that our project on building collaborative responses to traffic survivors of domestic violence and sexual assault has put together. And these are also in the handout. We have the contact information. You'll get the PowerPoint again. And want to highlight one on building collaboration with response with healthcare, 10 action steps for building your collaboration strategies. And I also want to take a minute to invite you, and you will receive a formal invitation to participate in an upcoming training or institute on building collaborative responses to support survivors of human trafficking as a collaborative with a multidisciplinary team. And actually, both Katie and Dr. Aaron participated in a training. That's how we met them. And they participated in this training a few years ago that Futures organized with the support of OVW. So we're organizing now virtually this institute. And so if you are part of a team, work with a team, you're invited to participate. And we'll send more information. And in the next slide, we have also, we just shared the link for the SurveyMonkey form where you can provide your feedback. We really appreciate your feedback. And also a certificate of participation, you can request it through that, to that form. And we'll share the resources. You can contact us as well for any questions. And also, I want to take a minute to thank both Katie and Dr. Aaron for their co-presentations, great information, great experiences, and thank you for your commitment. And also everyone that participated for your work and support with survivors. And I know you have a lot of great experiences as well that you could share with others. And also thank you to the facilitators, the Tech, Vivian and Jen, who are in the background, and also the captioners and translators. And so any questions? I think that that's all the information that we wanted to share. And thank you again for participating. I think we're ending on time. And any questions, again, feel free to contact us. And we're also available for support and any technical assistance that you might need, or that you could be helpful for you in terms of resources or working with your collaborative. And have a great rest of the week.